And I'm really excited to introduce Dr. Ida Sim, who's a primary care physician, informatics researcher, and an entrepreneur who co-directs the Informatics and Research Innovation at UCSF's CTSI, Clinical and Translational Sciences Institute. She's developed novel technical and policy approaches to build digital infrastructure for data sharing as a public good, and has co-founded a number of organizations. I'm going to keep the introductions short to give Ida more time to speak. So go ahead.
Great, thank you everyone, and thank you for putting this on. This is an implementation of digital interventions in the new normal, abnormal. I actually lose track of what's normal or abnormal, so we will just leave that. But I think everybody realizes that in this time of social distancing and the pandemic, that virtual care is super important, and that remote monitoring in addition is also very important. Patient-generated data, which I define as being data from sensors, from other sensors that may be around your home, for example, not just the wearables, home medical devices like BP cuffs, and then patient-reported outcomes. It's patient-generated data that provide a remote window into patient health states, which is so important now as people are not coming to the clinic nearly as much. And with a lot of innovation, I've heard some of the innovations described already earlier in this hour. The question is, how do we get from here, which is 1,000 flowers blooming, which in my mind just leads to a lot of seasonal allergies. Where do we really want to go? Well, we actually don't want 1,000 flowers blooming. We actually want a small bouquet, right? We want the right flowers together for the right purpose, for the right person. And it's really challenging this arrow is really challenging. And I'll use an example just here at UCSF. Let's just take an example vignette of a patient at UCSF who has high blood pressure. And these are actually projects that are going on at UCSF right now. Population Health is working with patients like Miss P, giving her an iHealth wireless cuff. It connects through MyChart. There are all these pieces together, and they use the UC Davis Better Blood Pressure Program to funnel blood pressure data to a team management. Let's just say that Ms. P is also a strong supporter of clinical research, and maybe she's enrolled in the Optima for BP research study, which is ongoing in our clinic, which is from cardiology, and that uses artificial intelligence to advise doctors on the next best therapeutic step to either increase the dose, add a new drug, for example. And in this project, Ms. P gets an Omron wireless cuff, and she has an Optima for BP smartphone app. And of course, now with the pandemic, UCSF Health itself is asking patients to self-report their home blood pressure readings via MyChart. You can see where this is going, right? This patient's going to get confused. Which apps, which sensors, which programs is she using with UCSF? Why is it that her data is going to her primary care doc, but not to her cardiologist? And, at some point, she can start to feel uneasy about her data relationship with UCSF. And here we're just talking about blood pressure. We're not also talking about blood glucose. We're not talking about, PROs. You can imagine this can really multiply to be a problem. And just graphically, just trying to show this in a table form, you've got different clinical units who are using different tools, different cuffs, different integrators, delivering the data to the doctor in a different way. We've got different clinics who are sort of going off on their own to do things. And then we've got research projects that are also, addressing each of these pieces. And overall, it just adds up to a lot of pain points. So taking it from the perspective of UCSF, and for those of you, I'm very happy to see people from outside of the country even, just think about it, as a healthcare organization, right? What are some issues about that? Well, with multiple projects, building and rebuilding the same patient-generated data infrastructure to ingest the data, store the data, send it around, it just multiplies the cost, quality oversight, and security risks. And this fragmentation really impedes governance over the projects that are being done by the multiple faculty, the multiple clinics, and then the health system itself. I think it's a real challenge for patient trust as well. As a patient, I may be using a number of different devices, not knowing where they're going, starts to erode potential trust. And then UCSF has a harder time managing that data relationship because we don't have a clear view of what sensor and what data is coming in and being used by different parts of the health system and on the research side as well. And of course, because we're a research university, we also do actually want to collect all this data, right? From the different blood pressure cuffs and the glucometers and the step, sensors. But we want it in the same format, and we want to have clear consent so that we can use that for, for other research later. And we also want the data to come in and then go back out to the clinician in a way that makes sense for us, at the pointy end of the workflow when we're actually taking care of patients. And if we do this sort of one-off digital implementation, we kind of lose control of how all the pieces might fit together. And it's fine when we're early on, in digital health innovation, but I think we're getting to the point where we really need to think about how these things are going to come together, because these pain points are just going to get more painful over time. Now, I have a separate approach which uses open source tools and open source, approaches, but a very common approach that's being taken, and actually is being taken by our health system at UCSF now, is to use Epic, which is the EHR that we're on, in the MyChart patient portal. So here you can see that you can order a blood pressure collection from a patient, okay? You can say how often they should collect their blood pressure, what are their thresholds that you want to be notified for, so you can customize the thresholds for your particular patient, which is super cool. You can see this is just like an order screen, and so you just accept, and off you go, you've made the order. You can also manage the workflow. How often do you want to get a report? What are instructions to the patients? If they're abnormal, if the threshold is exceeded, you want that message to go to you, or maybe to go to your nursing pool, right? So there's support for notification workflows. And of course, there's one for blood glucose, but a similar one for blood pressure. And then once you put in the order, just like you would order, any lab test, the patient then needs to go do something. And here, the patient would actually connect their wireless blood pressure cuff through, it says Fitbit and Withings here, but that's not right for this example. They would connect through Apple Health Kit or Google Fit, okay? And then the data would come in and would go directly into Epic. And then they also get to see their data on MyChart, and then the clinician sees it on something called Synopsis, which is another part of Epic. And here you can graph both the clinic collected blood pressures and the patient generated blood pressures on the same graph, okay? This is just starting at UCSF, and great excitement, because it's going to end up like this, where the clinical units are, really going to work with the medical center and use this approach of Epic MyChart. These are the cuffs that can be integrated from Google Fit and Health Fit, and then all the data shows up in Synopsis in Epic. So much cleaner than the previous one. And you would say, well, how about that? Is that good? Here I would say, let's back up and say, who are we taking care of, right? In primary care, I'm at the DGIM, General Internal Medicine. We have 25,000 patients. Here I've got my quick poll that's just popped up on my screen here. So just get rid of that. Okay, are people seeing my quick poll? All right.
No, we're not seeing the poll, Ida, sorry.
Okay, it's popped up right in the middle of my screen here. There's a lot of diversity in our patients, as you can see here. Lots of people speak different languages. Courtney has gone over some of the issues of, access both to internet technologies and also digital literacy, which obviously comes up. I'm not going to talk about those issues. I'm going to talk about what it means here for using just the Epic and MyChart approach. So as a pro, there are many pros to this, right? MedCenter has full control. All the clinical units are using the same approach. The clinicians get the data in Synopsis. Remote data is stored in the EHR, and it's good for billing, which is absolutely important. And it's device agnostic, right? We're using Apple Health and we're using Google Fit. And very importantly for patients, MyChart is a trusted one-stop shop for a lot of EHR activities. There are some cons, though, that I want us to be thinking about. MyChart is not user-friendly, and usage is not 100%, though it's now 80-something%, with the pandemic. Tremendous amount of user training and support is needed. But there are equity issues, I think, about using just MyChart. MyChart does not support character-based languages like Chinese. And this approach, HealthKit data stays on the iPhone, but with Android users, to use Google Fit, the data is being shared with Google. That's just the way it works. And so we need to be thinking about, are we exposing our patients to sort of additional privacy threats? And for a medical center like us, which is, an academic one, I struggle with how digital health research fits in. Because if we stay with the Epic MyChart approach, we have to use Epic's decision support tools, which are kind of clunky. We're restricted to using Epic's user interface, which is kind of clunky. We're restricted using commercial devices that integrate only with HealthKit and Google Fit. That's a restricted set of devices, of course. What if we're partnering with, colleagues at Berkeley who have a new sensor? What if we, there are many, many reasons why we don't want to be restricted. And then MyChart doesn't support patient-facing decision support. So that really limits the kind of research that we can do to bring digital innovation in. That's been a problem before. We really want to have more extensibility and flexibility so that we can get to these individualized bouquet. And I would now add to this that we don't want just that one bouquet, right? We have many different bouquets that we need for different users. Some people are more technically literate. Some people have Android. Some people, need many, many sensors because they have a lot of chronic conditions. Some don't. And it's going to change over time. How do we be flexible so we meet patients where they are and still manage the flow of innovation and security that we need in our implementation? COVID has made everything a lot more challenging right now because there is so much pressure on the clinical IT side to deliver innovations. All innovations touching our UCSF EHR now require executive level approval from digital recovery solutions, which just makes the bar even higher for doing digital health research. So I'm concerned about how that's going to add up, right? So in summary here, I think just to be thinking that to be successful, there are individual innovations that we need to study, as you've heard already. We also need to be thinking about how these innovations come together to be useful and usable by individuals, right, as individualized bouquets for each person that might change over time. We need to think about how it's sustainable for systems, health systems, large ones, and particularly for academic medical centers, how we balance the tension between digital innovation and the need to have control over our technology and our security and our patients' experience. And all these pressures, I think, are only going to get higher as, in the face of severe financial and staffing constraints with COVID-19. But I think it's really pushed us to think about governance and about how we implement technologies that need to be tested, but in the end, we do want them integrated into the healthcare system and what that looks like both for our patients and for us. And I'll stop there.
Wow, it's a tour de force, Ida. I'm wondering, I don't see any questions posted. I know we're at the hour, but I'm hoping people can stick around for a second, and so can you. I'm just wondering about, like there's an antitrust suit right now with Google, and I'm wondering, your comments about how Epic and the medical center only work with certain, companies and their digital projects, and I'm just sort of curious if there's a movement to change that.
Oh boy, that's a tough one because, these are private actors, right? So Epic is working with Amazon Web Services. They also have a partnership with Microsoft. UCSF has established relationships with Amazon and with Microsoft. Google's somewhat left out of the party right now. That may change in the future. But I think there are decisions that need to be made at the institutional level that then impact us. And they end up, there was this whole breach, right, of data, and UCSF had to pay a ransom. So that's the context in which digital technologies need to be managed. And so, those of us who are doing research, if we want our work to have impact, need to be thinking about how we fit into that bigger picture, and then incumbent upon us at the leadership positions at an academic medical center to make the case that there needs to be room for the kind of digital innovation that we do.
Yeah. Well, I'm not sure if there are any other questions from the audience. No. I mean, I don't know if any, go ahead.
Sure. Just one comment I just want to make, and it is a comment, it's not a question. But in listening to this, what's interesting to me is to think about the policy landscape. And it's just worth noting that there's a lot of what it enables the funding of the telehealth services right now in the COVID era is possible because emergency regulations were put in place at various levels, such as within the Medicare program or within certain state programs and things like that. And it's really not clear where those are going to land when we come out of COVID. I mean, not helped by the fact that we don't know what's going to look like as of tomorrow, the federal level, but there's an awful lot as reflected here that people are doing to adapt. Some of it is clearly being done because we're kind of forced to be in it, and maybe we'll look a little different afterwards, but there's also a lot about things that really work well for patients and things like that that may actually be worth sustaining as we go forward. And it just remains a question mark as to what that landscape will look like for paying for some of those things when we move past COVID.
Yeah, it's interesting to think about how the landscape will change completely in terms of the production of digital health provision with COVID and with the end of COVID, and whether we'll see some sustained differences in how things are delivered. I don't know if any of the panelists have a final comment. I did want to say that this is the first in a 4-part series, and that we will be having discussions in the coming weeks around different methodological approaches to address changes and interruptions in research due to COVID, ethical issues that come up around changing our study designs and our delivery of healthcare due to COVID, and also discussion of study design and how to deal with things like COVID when they come up. So I want to encourage people to attend those meetings as well. If anyone has a final comment, I'm happy to open the floor. And if not, I will just, send a shout out to the 4 speakers. Amazing work that you're all doing. And hopefully we'll see you in the next session when we have hopefully good election news to share as well.